Dr. Weinberg is certified by the Royal College of Physicians and Surgeons of Canada and has been in practice since 1996. He was the division head of plastic surgery at Trillium Health Centre for 15 years and continues to be a vital member of the plastic surgery department at the hospital, active in surgery and teaching. He is the founder of the Mississauga Cosmetic Surgery and Laser Clinic, a distinguished surgical facility, and sees surgical patients at the Toronto Plastic Surgery Clinic as well. He's the co-founder and co-medical director of the Carlton Skin Clinic, the leading facial skin cancer facility in downtown Toronto. Dr. Weinberg earned an honors Bachelor of Science and a master's degree in medical biophysics at the Princess Margaret Hospital before obtaining his medical degree in 1990 and completing his plastic surgery residency both at the University of Toronto. He is actively involved in many societies for cosmetic plastic surgeons in Toronto and Canada at large, including Canadian Society of Plastic Surgery, Canadian Society for Aesthetic Plastic Surgery, and Ontario Society for Plastic Surgery. Dr. Weinberg is also the past president of the Medical Staff Association at Trillium Health Centre, affiliated with the University of Toronto, and previously sat on the Trillium Health Centre board. So thank you so much to Dr. Weinberg for joining us.
Hi, everybody. Abigail, I want to congratulate you on your Melanoma Canada efforts. They're so crucial. And we know from early detection, just a plug, we know from early detection, the earlier we get these things, the better. And certainly in Ontario, it's really terrible because the wait time for dermatologists is so long. So we're often seeing people presenting late. So education is really key. Thanks for that long introduction. I can't believe that's me, but I guess it is. This is one of the hardest talks I've ever given because as a reconstructive and cosmetic surgeon, we do lots of really cool things. But when I was thinking back on melanoma, we don't really see a lot of patients back for revisions or saying, hey, listen, this is really bothering me. Please, can you help me with that? And that's patients in my own practice and from other people. And I see in Mississauga probably the vast majority of melanomas. So I just want to say this is a melanoma. It's a really, I put a couple of melanomas up not to as just part of education. This is a kind of a melanoma that we're seeing that's a nodule, a pink nodule growing on a dysplastic nevus. And it's really dangerous because it shows up as a nodular melanoma really deep, and most people don't know what it is because they're looking for a black thing. So when we take out a melanoma like this, the majority are shallow, meaning less than 1 millimeter. So usually when we take those out, we can close the wound just together. And with a margin, I'll go over the margins. We usually end up with a straight line scar that usually ends up being a pale spread scar. Some of them are deeper, like this would be a deeper melanoma. And for that, we'd have to put a skin graft on. That's a scar that I'll show you a picture of, and we can revise those. Some have node dissections, really a sentinel node biopsy. Really, it's not a node dissection, but a sentinel node biopsy. Those scars are pretty small, so most people don't complain about those. And usually the surgeons who we work with in the head and neck and general surgeons, they're used to hiding those scars pretty well. And few need kind of big flaps. I'll show you one. It's not to, it's really not to scare anybody, but it is a big scar. So towards the end, if you want to look away, that's okay. Just to remind you, this is a very deep melanoma on a young person's thigh. So this needs, so melanomas, we either call them shallow, less than 0.8 or 0.1, medium depth, 0.8 to 2 millimeters, and deep 2 to 4, above 4. So the margins on either side would be 1 centimeter. So on that small little thing that I showed you in the slide before, the thing's about 1 centimeter, then you'd take 3 centimeters across and you'd have like a 7 centimeter scar. Obviously, the bigger ones where you have a 1 to 2 centimeter margin, a 2 centimeter margin, the scars are longer. Luckily, they're on the trunk mostly and on extremities. So they're not a huge issue for patients. In terms of scars, the best thing about these, getting ready or doing the surgery is to plan well. So, for example, if you had a scar going across your head, if you had a melanoma on your forehead, we'd put a scar across, we wouldn't put it down. And then if we had to do some kind of reconstruction, we'd really try to go, if you had a bigger melanoma above your eyebrow, we'd go up and around. We wouldn't really go a vertical scar. And like I said, I went back and I thought, well, maybe it's me. People are not asking me. But then I asked a bunch of surgeons, and we rarely are asked to modify these scars. In addition, a lot of scars on the trunk and on the extremities are difficult to improve. I suppose most people don't get that. In my way I think about it is maybe 40% of scars are due to the type of skin you have, the kind of person you are. And then 40% are really the location. So 10% is how we do it, and 10% is maybe who we do it. In my head, it kind of works out like that. So a lot of them are not modifiable, and people are not really bothered a lot by them. I just took this off the internet. So you can see to the left of the slide, that's a spread scar, and that's really not the best scar. Most of them are better than that. And to the right, that's probably a skin graft, and that surgeon is planning to excise that skin graft. So you can see that that skin graft to the right, once removed, will look like the scar on the left. So I would say that's a below average scar, but not atypical if you were to take off a 2-centimeter melanoma. And so if they ended up with a scar just as on the left side, going across the wound, so the whole wound, it's not a terrible scar in my mind. I'm not saying that it doesn't bother patients, and we have a range of patients that really bothers them or doesn't. Some it bothers, some it doesn't bother. But that would be a very significant scar from a very deep melanoma, probably the worst you could expect. Here's the skin graft. So obviously, when we can close things, primarily just close them together with sutures. We tried that. Sometimes you have to put a skin graft on. This skin graft here is a skin graft that would be completely and easily removable. So basically, you'd take that off and you'd end up with a scar maybe 3 to 5 millimeters wide. It may take you 2 tries. You could probably do it in 1. This is not a melanoma. It's a squamous cell carcinoma. I didn't have a melanoma to show you out of my patients. But basically, it's not a common site, but it's not an uncommon site. And then basically what you can see, he has a skin cancer on his lip. I had to show you this to show that I can actually do something. And so I took off half of his lower lip, reconstructed it. You can see the scars are really pretty good. And then you can see that he's orally competent. So in other words, he can whistle and go from a straw. So we do get melanomas unusually on the lip. And there are lots of things we can do. And obviously, it's easy for someone to hide these because they go in the nasolabial folds, the nose smile line folds, and they go in the crease above the lip. I think if you're squeamish, you may not want to see the next slide. So this is an example of a flap. So here's a flap, so truncated, but this is a metastatic melanoma, and it's about about 10 centimeters in diameter. It's about 5 centimeters in height, and this needs a really large reconstruction. I'm showing you a fresh scar. Obviously, this is not modifiable, but it's life-saving, and an older gentleman and would probably not really come back and say, this is a terrible scar. Can you fix it? I think that his overwhelming sentiment would be, I'm alive. I hope I don't get more. Thank you. Please follow me and help me out. So thank you very much. Short and sweet.
Thank you so much, Dr. Weinberg.